It's a real pleasure and honor to have Dr. Zacharia to give us this lecture on LIT and as neuro-oncology. When I started in neurosurgery, it was gargling tumors. Now it's going every year from one technology, one sophistication to another. So really looking forward to this lecture. Thank you, sir.
Yeah, and truly appreciate the invitation. This has been really spectacular so far, and so I think this dovetails nicely with Costas's presentation on SRS, because this is where a lot of this comes into play. But this is going to be an overview of MR-guided laser ablation, and I have these disclosures, none of which are relevant here, and did this in conjunction with one of my colleagues, Dr. Hamp. So we're going to go over just some background of laser interstitial thermal therapy, talk about the operative procedure and some technical pearls, and just briefly review some of the more current literature, and then show several case examples. So the laser ablation thermal system is FDA approved in the United States to necrotize or coagulate brain parenchyma. And basically the procedure is the insertion of a small laser probe to a target, and then heat induces cellular death. And there's really two fundamental parts. There's the laser applicator and then the actual workstation and business end of it. This goes by a variety of terms, all of which are really interchangeable. It goes by laser interstitial thermal therapy, or LIT, or laser ablation, MR-guided laser thermal therapy, etc. All of which are really connoting the same thing. So ablative procedures in neurosurgery are obviously not new. This dates back decades to the early days of neurosurgery, radiofrequency ablation, chemical ablations. And so where does this come into play? Even in the 80s, this was being done. Hyperthermia for brain tumors. There's notion of using different types of lasers. And so it was felt that lasers definitely had the potential for precision delivery of intense thermal energy, but it really required refinements in the laser technology, advances in neuronavigation to actually make it safe, to make it reliable and effective for a broad spectrum of intracranial pathologies. So laser is light amplification by stimulated emission of radiation. It emits light coherently, so it has this very tight spatial coherence and stays narrow over a long distance. And so the components to the LIT system are a workstation that's typically situated in an MRI control room. You're going to be acquiring real-time MRI imaging, displays temperature data, and then calculates how much of the area you've damaged. The laser applicator itself is a fiber of various diameters depending on the system you're using. It has a cooling system that's oftentimes either a gas medium or liquid medium, and that's typically placed in the operating room. So a variety of different wavelengths are used, the most common being 980 nanometers, has a very tight transition zone. It strikes a balance between the energy absorption and exposure time. So as the wavelength changes, it correlates to longer exposure times. And so striking this balance that was part of the original kind of design of these systems is to be able to get a tight fall off, an effective ablation over a relatively short exposure time. So the properties that are useful in neurosurgery here, the absorption coefficient of pathological tissues is typically higher than normal brain. And so that results in preferential ablation of that tissue. And there's a steep fall off of temperature at the brain lesion interface. And so these are just some of the physical properties that afford tight ablation within the brain. One of the main advances was MR thermography. And so this is utilizing MRI technology to detect temperature increases from how the protons respond to water and thermal energy. It's a gradient echo based acquisition. Images are generated rapidly every typically 3 to 4 seconds. And it provides real-time visualization of the heat delivery and thermal damage during the procedure. This has really been one of the main advances. There are 3 commercially available LIT systems. One is by Medtronic. The system's called Visualace. Monteris makes a system called Neuroblate. It has several unique features. There's a side fire laser, and we'll kind of get into the nuances of that, but most of these lasers fire concentrically. It has a remote robotic control that allows you to move the laser fiber in the Z plane, basically in and out. And the newest platform is by ClearPoint, a company that has really been in the MRI space in terms of MR-guided biopsies and procedures. And again, they have their new laser fiber. The techniques are really similar across the platforms here, with some subtle differences. I personally have utilized the Visual Ace and NeuroBlade system. I currently use the Visual Ace system, but they're all similar across the spectrum. Okay, so the basic operative procedure involves image registration, planning your trajectory, insertion of a bone anchor, and then delivery of the laser catheter. Unless you're doing this in an intraoperative MRI suite, you're typically then transporting to MRI to confirm laser location and then ablating the target. So my personal workflow for complicated trajectories, I typically plan this preoperatively. I utilize the BrainLab planning software, but any planning software is appropriate. I then utilize a ROSA robotic system to place the fiber, but again, any navigation system is fine for that. And so I would typically fixate the patient in the ROSA system. If clinically indicated, you could do a biopsy through the exact same position. You're going to place the bolt and fiber in the OR and then transport to MRI. You're going to get your anatomic and temperature map data and then proceed with the ablation. After the ablation, you'll typically get another MRI. You could get one with diffusion as well, allow to see your ablation zone, and then you remove the fiber and then wake the patient up in the MRI scanner. So again, registration is really platform agnostic. It doesn't matter. You use what you're comfortable with. You don't have to change your workflow. There's a high premium on accurate targeting. And so you may want to consider more stringent registration techniques, whether that's with bone fiducials, intraoperative imaging, a robotic system, but certainly what you're comfortable with works. So again, this is just an example from the BrainLab software. This is for a brainstem cavernous malformation that we were ablating. It's going to be similar to a biopsy or a DBS trajectory planning. You're going to choose your entry and target. You want to avoid cortical vessels and sulci. And ideally, you want to be along the long axis of the target. Again, as I mentioned earlier, most of these fire concentrically. And so if you have a long sausage-shaped lesion, you could go in and out, but you can't go side to side. And so you want to be in the center along the long axis of the lesion. Okay. Okay. So again, you're going to align your trajectory, and then typically I'll do this with a twist drill. Again, with or without a biopsy, you're going to place your bolt and then place a laser fiber to a predetermined depth. This is what it looks like in the MRI scanner. You're going to get an initial acquisition to confirm that the laser fiber is placed where you want it. You get baseline anatomic images, typically with a half dose of contrast, and then you're going to get your temperature data. This is what the thermal map looks like. You give a test dose of the heat once you've confirmed that the laser's working, confirms the location. You're able to see the heat spread in real time. You could choose your temperature targets, and we'll talk a little bit more about that. And then there are parameters to keep the thermal ablation from damaging, more eloquent areas. So some consideration. Certain structures are heat sinks, so they conduct heat away from the laser fiber or absorb the heat in such a way that they sustain no damage. So you can come into close contact with those without fear of damage. Things like high flow vessels, ventricles, cisternal spaces, which is what affords you to be able to treat near those structures without damage. You want to avoid any particularly high temperature at the laser tip. I'm just going to induce a steam event or boiling. And so there are ways to mitigate that as well. So choosing your temperature parameters, you're able to place targets with all the systems. You're basically in areas where you'd be concerned about overheating and causing irreversible coagulative tissue death. So the typical limits are usually 45 to 50 degrees centigrade, because tissue death starts at 45 and is absolute at 60. And so you could set there, and you see here on the screen, if you see these little kind of purple hash marks, that's saying, hey, we don't want to get too hot there. And if the temperature is rising in that area, the laser will trip and stop. So again, just to summarize some of these things, so improve laser functionality, improve the absorbance and short ablation times. The cooling catheter has really narrowed the transition zone, so allowed a steeper fall off, and you're getting real-time imaging acquisition, typically every 3 to 4 seconds. Each software platform uses a different equation, but basically they could summate the damage estimate based on temperature and time to tell you how much of the ablation you've ablated. And the improvements in neuronavigation have afforded really dramatic improvements in the safety and efficacy. And so again, one could imagine, this perhaps being some hybrid between, completely non-invasive radiosurgery and a more invasive open craniotomy, typically very short procedures. This in part depends on your setup. It's a stab incision with just a single absorbable stitch, simply a brief overnight stay. And particularly in patients, and we'll get into this when we talk about indications, it doesn't interrupt chemotherapy, radiation, and there may even be a preference for lid over craniotomy in some of these small series. So how do you assess treatment response? What you'll typically see is a peak of flare signal and enhancement in the first 1 to 2 months afterwards. Again, this may be an opportune time for blood-brain barrier modulation, T-cell priming, and there's a lot of kind of interesting work going on here of using lit as an adjunct in certain tumor types. And then over time, you'll see a decrease in the tumor volume if you follow these with serial imaging. So what are the primary applications? Tumors that present surgical challenges, deep-seated lesions, people with prior radiation, prior craniotomies, patient comorbidities, and radiation necrosis. So where do we use it most commonly? So post-SRS infield recurrences is probably the biggest, where you're having trouble differentiating tumor recurrence versus radiation treatment effect. And perhaps that definition is not even useful in this case. For recurrent glioblastoma, nodular disease that's not amenable to re-resection, you could use it in an upfront glioblastoma, deep-seated lesions, lesions that are crossing the corpus callosum, butterfly glioma, radiation necrosis, and then some less common indications that we'll touch on as well. Some relative limitations. In general, the concentric lesions treat it with a diameter of about 2.5 centimeters. Now, depending on the tissue, sometimes it's more, sometimes it's less. Typically tumors that are less than 10 cubic centimeters, but there are ways around this. You can treat a longer lesion by pulling back along the trajectory. You could use multiple trajectories. And so I think people have been pushing the boundaries as we've become more comfortable. Stellar pituitary lesion doesn't lend itself, and then brainstem a little bit kind of later to the game, but people are getting more comfortable doing it with the techniques and the technologies, and certainly this is a burgeoning area of treatment with laser ablation. So, as one might expect, if we go back to the 90s, the proliferation of literature publications on lit has increased dramatically. And so just briefly, just hit on some of the key things in the literature. So it's utilized for metastases. It's probably it's kind of bread and butter, most common indications for radiographically progressive metastases after SRS. You could do a biopsy to confirm whether there is in fact tumor progression versus radiation treatment effect. It can be synergistic with SRS. There's even a possible role in newly diagnosed brain metastases. Right, there's some question of how good the local control is with SRS alone for larger brain metastases, and so people are working on a small pilot to do preoperative lit followed by SRS to see if we can get some synergy between those two. Again, I mentioned its use in glioblastoma. Upfront glioblastoma may be not amenable to other modalities, so deep-seated lesions, unresectable primary glioblastoma like butterfly lesions you've seen here. So again, all of these are based on small series. There's been no large-scale, RCTs, but colleagues, across multiple centers have looked at this and shown overall, improved overall survival, progression-free survival, relative to a biopsy only. So in a case like this, where we know the patient's universally going to do poorly, can we do better? And so again, there was a pilot RCT in the Netherlands, which showed feasibility and good safety profile. So I think there's a lot of interest kind of in this area. In addition, can there be some, benefit opening blood-brain barrier with the heat, and then also augmenting the immune response? This is definitely sacrilegious in the presence of Professor Defoe here, but the group, Henry Ford, has even looked at doing lit and stage lit for insular glioma, even for low-grade insular glioma. They showed that it's feasible with reasonable rates of cytoreduction, a good safety profile. Again, so people learning more about this technology and these techniques and pushing the field. Been utilized in meningioma. I think we all know that when you have these multiply recurrent meningioma, they can become extraordinarily challenging. And once you've exhausted surgery, radiation, that our medication options are limited. And so this is a non-radiation ablative technology that can be used synergistically. I mean, has been used in several series with reasonable responses. So again, there's a whole spectrum of pathology, locations, tumor types. These are just several examples here. We'll go over some specific case examples, but this is what you'll be seeing on the left of each little blob is the real-time heat. Obviously, again, if red is hotter and blue is cooler, and you're seeing the heat spread from the laser in real time. On the right side in the orange is the thermal damage estimate. Those are the areas that have been heated long enough and at a high enough temperature to be completely damaged. So you kind of get a sense of spectrum of what you're seeing when we're doing this in the MRI scanner. This is the screen you're looking at. So as an example here, this is a 64-year-old gentleman, mild word finding difficulty, had this small mass in the insula. He underwent a biopsy at an outside center, was diagnosed with an anaplastic astrocytoma, and then he had undergone temozolomide and radiation there, and then presented 6 months later with aphasia and confusion that showed significant interval growth. So the question is what to do here: craniotomy, biopsy only, perhaps consider enrollment in a trial, Avastin, observation only. Could this be radiation treatment effect? And so in this case, we were able to aspirate the cystic components of this, the necrotic components, see what that looks like real time in the MRI scanner, and then ablate this lesion. This is the characteristic appearance you see immediately afterwards, this kind of eggshell rim of enhancement around the ablation zone. And so you're able to do this effectively. This patient actually went on to survive for quite a bit of time with this lesion. This is a multifocal glioblastoma in a 58-year-old gentleman. An MRI revealed this kind of larger anterior lesion, a smaller posterior lesion, needle biopsy that demonstrated this to be a glioblastoma. You can consider resection of the dominant lesion, but obviously the multifocality of this kind of raises concern for more diffuse spread. So he initially was treated with IMRT and temozolomide, and early imaging showed some decrease in the lesion, good performance status, and now it's more reasonably sized. And so do you leave it like this? Do you consider treatment at surgical resection or some kind of treatment at this point? And so what we opted to do here was to do a laser ablation. This happened to work out nicely. You can see that with a single trajectory, you're able to hit both of these lesions in the long axis, come at it from posteriorly. You see this is the heating of the posterior lesion. We were able to also treat the anterior lesion. And this is kind of the immediate after effect on the bottom. So the preoperative on the top, the immediate after on the bottom, you see the ablation zone. 1 month after, you see a transient increase with some increased edema. And then you see the 3 and the 6 month and really remarkable benefit. And these are really relatively low morbidity procedures with minimal interruption, again, of systemic therapy, chemo, and radiation. And this is 9 months post-ablation in that patient. This is where it really shines in the recurrence necrosis. Is a 40-year-old woman with a metastatic triple positive breast cancer. MRI revealed several brain metastases, and she underwent radiosurgery. Multiple of the lesions responded nicely, but she had the cerebellar lesion, which showed some increased enhancement and edema about 12 months following radiosurgery, and they had progressive worsening on serial imaging. So again, options here: observation, steroids, Avastin. But now we have this fourth option, laser ablation. We all know the risks of long-term steroid use, particularly in the setting of patients who are getting immunotherapy and the need to get off those medications, potential risks for Avastin. And so we asked ourselves, well, what are we treating? Are we treating recurrence? Is it radiation necrosis? We heard the lecture earlier about utilizing a variety of radiology modalities to try to determine that: perfusion, spectroscopy, PET scans. But even with that, it's challenging. Biopsy, even unto itself, has a risk of sampling error. And so is growth on serial imaging alone? The symptoms matter, where all these things come into play. And I think, there's several schools of thought. Some people don't even bother with a biopsy and treat no matter what, because it's equally effective for radiation necrosis and recurrence. Other groups feel that the biopsy is important because if it shows active tumor, they'll re-irradiate after the ablation. So I think this is a question that we're still asking, but it's quite effective. And you see in these early kind of multi-center prospective but not randomized trials, stabilized KPS, preserved quality of life, and a steroid sparing. And so this was the ablation for this young woman. You were able to get a nice ablation, again, overnight stay. This is that immediate post-operative with that kind of eggshell enhancements. And then you see 6 months following. There's a little bit of a whirlwind, but I hope that gives you just an overview of kind of the burgeoning role of laser ablation in the tumor world. There's a whole epilepsy piece as well, which obviously is not time to get into here, not our focus. But I think is a very nice adjunctive tool. And like all these tools, it's a tool that you add to your armamentarium to allow you to offer the best thing for the patient, for the pathology at the time and location. Is not a supplanting doing traditional surgery, is not supplanting traditional radiation procedures, but again, is another technique and another modality that I think just expands our ability to safely and effectively treat a wide variety of patients, particularly complex patients.
Thank you. Thank you very much, Dr. Zacharia, for this timely lecture. Certainly in the UK, LIT has been on a big on the hot recently. And in terms of, as you said, it's a part of the armamentarium. And in terms of the insurance from your US side, the insurance covers the procedures?
Yeah, I think that was a challenge early on, right? With any new technology, you get FDA approval, but that doesn't mean that it's going to be covered by insurers. But there are now billing codes specifically for laser ablation. It is now covered by insurance. For us, it has what's called the 0-day global period. So everything around it can be billed for. So now it is reimbursable.
Thanks. And in terms of the time that it takes and the expense, just for us to have an idea of that, because certainly, we have intraoperative MRIs and they usually end up taking the whole day. And obviously, if they are, for the right operations, they are great, but sometimes you have to do every operation with intraoperative MRI to be good at it. And so what are your thoughts around the cost effectiveness and the expense and the outcomes compared?
Yeah, I mean, I think as regards to kind of placement and doing the actual procedure, if you have an intraoperative MRI suite, I think it makes it for a very slick and time-effective procedure. The actual placement of the fiber is like doing a needle biopsy. It's marginally longer than that, maybe 5 to 10 minutes longer than doing a needle biopsy. So where the biggest time comes on my end is we don't have an intraoperative MRI. So we do the procedure, and then we need to transport the patient intubated down to the MRI scanner. And that really, actually, that time period is really the biggest time. So if you're able to do it in an intraoperative MRI suite, do what in essence is a biopsy procedure, it's actually a relatively slick procedure. The image acquisition, the actual laser fibering is not very long. That's probably anywhere from 30 minutes to an hour. The placement's probably about 30 minutes to an hour. So, I mean, it can be a short procedure. I think when you add in the transport and the moving the patient onto different beds, it does make it a longer procedure, but it's relatively limited OR use time. And so I think it can be quite cost effective. And when you bring into the fact that these are patients who either wouldn't have had surgery before or may have had a more prolonged hospital stay, I think it can be quite cost effective.
Thank you. The last question is that I know that you are adult neurosurgeon primarily, but is the technique being used in the pediatric side in Penn State, or is there any plans to use it in pediatric side?
Yeah, it's extensively used in the pediatric world as well. I mean, I think it's particularly for epilepsy, but there are a lot of unique things that it's used for in pediatrics, things like hypothalamic hamartoma, which have been notoriously difficult to treat. It's really exceptional for. And again, I think the indications are somewhat similar, right? Even though metastases are probably the most common indication, and we don't see that as much in that population, small, recurrent, difficult to access lesions can be safely, ablated with this technology, even in the pediatric population. So there's no reason it couldn't be applied similarly in that group of patients.
Final question from me is that where do you see the advancement coming in lit? Do you see what's the thing that you want to see in lit?
Yeah, I think for me, I think the biggest is the planning software. I think as we better understand the physics of the heat spread, and this, we have one of our folks in our group is working on this as well. Being able to predict how the ablation is going to go based on the preoperative imaging, how to optimize the placement of your laser fibers, because right now it's really largely based on experience. And there's no way to tell you, hey, put the fiber here, or put 2 or 3 fibers here to get an optimal, safe, effective ablation. So I think that's going to be the next kind of series of advancements: improved imaging and improved software to allow us to plan more effective ablations.
Thank you very much, Dr. Zacharia, for this fantastic lecture. It's been very useful, and certainly I think it will be very reference for all of us who, which as more centers start to do the lit technique for various indications, as you said. So look forward to having you again.
I would absolutely love it.
To see where we are in future. Thank you so much.
Thank you.